Hi, I'm Dr. Marvin Natowicz. I'm a medical geneticist at the Cleveland Clinic and a professor at the Cleveland Clinic, Lerner College of Medicine of Case Western Reserve University. Today, we're very fortunate to learn from Karen Turner, an occupational therapist at the Massachusetts General Hospital in Boston. Ms. Turner is a patient navigator. Her area of specialty is in assisting persons who have autism go through their outpatient and inpatient encounters at the hospital and do so with minimal difficulty. She is a person of enormous creativity. And as you'll learn from today's presentation, she is working to help persons with autism and their families navigate the healthcare system in ways that are quite remarkable. Thank you so much for being here today, Ms. Turner.
Hi, good morning. First, I just want to say thank you so much for having me here. I'm really delighted to share about the work that I do, and I'm also really looking forward to our discussion as well, because I'm really interested in hearing your perspective on this work, what things you're seeing in your practices, as it only helps me continue to kind of grow and think about how to do this work. So during my talk today, I'm going to share about my role, which is a unique role as an OT patient navigator for people with autism and intellectual and developmental disabilities, as well as the program I developed, the Healthcare Inclusion Program for Developmental Disabilities. I'm going to talk about healthcare barriers for individuals with ASD and IDD, medical trauma and distress, some OT practice frameworks that I use for intervention, just to kind of help you think about and understand how I think about these situations, provide some interventions that I do that I've found to be really successful, give an example, and then share some patient and family and colleague feedback. So what is an OT patient navigator? So my role came about as a result of what was called the Autism Care Collaborative at Mass General Hospital, which was around 40 physicians, clinicians, parents that came together to figure out how do we improve the care for people who are moving from pediatric to adult services. And at the time, I was specifically thinking about the inpatient service. And so I was part of this collaborative. And one of the ideas or kind of the interventions this collaborative came up with was this patient navigator role. And so they actually approached me to see if I'd be interested, because I was already involved with a small team that would go around the hospital when there were episodes of distress with patients with ASD to help put together plans of care and support staff and the patients and families. And so I jumped at it, and it began with 8 hours a week, 8 hours a week, and then a few months later, we got more funding, it grew to 20 hours a week, and then in 2018, I got funding, full-time funding from the Ritterman Family Foundation for 3 years, so I was able to go full-time. And now this is a full-time position paid by the hospital in our Department of Equity and Community Health. So as an OT patient navigator, I do some traditional patient navigation. That includes helping with some coordination of services for patients, providing access to resources such as autism-friendly primary care physicians, specialists, etc., and providing emotional support to patients and families. But I still wear my OT hat, and I still do OT interventions. So that might be creating visual supports, putting together plans of care, thinking about helping caregivers to think about how they can best support the person within what we need to accomplish for the patient at the hospital, and then also supporting providers, whether it be general education to provider departments or providing education on specific situations. And then I also have a role with systems level. So looking at how can we improve different systems across the hospital to improve care, working with teams of people, and this is really one of my kind of most favorite things as well that I've done. So I knew that I couldn't do this job alone, and so I developed a program called the Healthcare Inclusion Program for people with developmental disabilities. And it was really a way to try to bring together a whole bunch of different departments that were separate from each other and kind of living in silos. And so it included individual staff and providers from the emergency department, outpatient specialists, procedural areas, inpatient, primary care, but with this kind of thinking about how do we pull people together to think about how to improve care, help people to network, etc. And so this was our vision, was really just to support meaningful participation and healthcare access for individuals on the spectrum and with IDD, and to provide individualized care through consideration of someone's strengths and abilities, while also thinking about how can we adapt what we're doing as far as medical tasks, our approach, the environment. I created, or I really networked and developed relationships with a large group of people. So I call them my MGH champions for autism and IDD. It's over 100 people now across the hospital. I literally could not do my job without them. They make me look really good. And so it's people, it's nurses, it's physicians, it's officers in our police and security, it's technologists, it's PCAs, it's spiritual care providers, social workers, therapy, etc., a large group, and a representation from all these different locations where I support people across the hospital, which is really just where our patients are going. So a little bit about the program so far. So since the program began in 2016, we've served over 625 patients and families, and this is over 1,200 distinct healthcare encounters. This is patients that are coming back multiple times across 55 unique locations in MGH. And the age range is, I've supported anyone from 1 to 80 years old. Really, the largest population of people that I support is in this transition age of 20 to 30 years old. Which makes a lot of sense because that's the age that my role was created for. So it's an age that really does need a lot of support during that transition. Probably going to surprise you that about 2/3, a little over 2/3 are male. And then when my program went full-time, so originally I would only support people with an autism diagnosis because I had such limited hours. But when it went full-time, I was able to expand to people with other diagnoses as well. So this started to include a lot more individuals with genetic disorders, whether it be Down syndrome, tuberous sclerosis, or other neurological conditions too, people with cerebral palsy, etc. And the reasons why people are coming will probably not surprise you as well, right? Because these are all of the reasons that individuals on the spectrum present to the hospital. So psychiatry was number one, neurology, gastroenterology, and then dental care, which we provide in our OR operating room under anesthesia for some patients that need that. And then a large bucket of other after that, which includes pulmonary care, infection, cardiac as well is a big one, and what I call proactive care, which are people who are reaching out for resources, like a specialist. So now I'm going to talk a little bit about healthcare access and barriers, as well as some considerations and interventions for people on the spectrum and with IDD. So there has been some really nice research out there, and I like the way in which these papers organize this, that there are these 3 levels of access barriers that patients face. There's the patient level, which is difficulties with regulating emotions or becoming distressed, differences in how people communicate, and differences within how people process sensation that can then make being in the hospital environment or medical setting really difficult. There's the provider level, so it could be limited knowledge about caring for people with ASD, use of communication that is not accessible for the person, maybe not being as flexible around thinking about how to provide accommodations, and not as supportive of partnerships with caregivers. And then the research has also identified the system level barriers, so stigma, the complexity of the system, which I think is an area where I've been able to make a lot of progress for patients and families, and also stigma. There are also a couple really nice papers that interviewed people on the spectrum to better understand their specific challenges that they have with healthcare access. And they organize these challenges by challenges with communication and sensory. So it's things like challenges with processing speed, so not being able to take in all the information from a provider, difficulty with communicating, interpreting things literally, and then misinterpreting a lot. This is something that happens that I support kind of individuals that are verbal communicators around a lot. And then also sensory barriers in the environment, like the bright lights, strong smells, sensitivity to touch and tactile so that it can make tests really different. And then challenges with body awareness. So this can be kind of where someone's body is in space, but also recognizing, someone may know they're in pain, but they may not be able to localize where they're hurting, or they may not really be able to describe exactly what that pain feels like, which then can make it really difficult for providers to figure out how to help them. There's also literature we know that when individuals on the spectrum and with IDD have a lot of co-occurring medical conditions, they have a lot more interactions with the healthcare system that then can create medical trauma. And one thing from these papers, a couple things I found really interesting was that the experience of trauma may be unique to individuals with sensory and communication differences, and characteristics of ASD may then alter what events and stimuli are experienced as traumatic. So I think that really comes down to making sure that we're not making an assumption that, for example, just taking a blood pressure isn't a traumatic event for someone, and trying to understand what is this person's experience of it, and then how can we reduce that. And then as a result of this, people can be in a high alert state beyond the point of the event. And so one of my early experiences was meeting with a parent, and I was trying to figure out about distress and how, what was it about coming to the hospital that was causing her son to experience distress. And she looked at me and she said, "Karen, he's distressed walking in the door. There isn't one thing for him that really sets him off. It's, his history over time." And that was so powerful to me but also so helpful, because it made me think, okay, we just need to be really proactive and start from as soon as people are entering the system to make sure that we're really mitigating and reducing any chances that we could be creating re-trauma for people. One of my mentors once said to me, "All behavior has meaning," and I love this, and I've carried it with me since then, because sometimes people can see behaviors and think, "Oh, that patient's behavioral," right? That's like a stigma. Sometimes I don't even like to use the word behavior because of some of the stigma that can be attached to it in the settings like that I see. However, when we only focus on behaviors and we only try to modify those behaviors, we're not really understanding what the root cause of it is. That's where I think part of my role is like in being a detective to figure that out. One of the frameworks that I use is a sensory processing perspective. And so this is really just understanding that we all have differences in how we experience the sensation in our everyday lives. And how can I then understand what's this individual's experience, and what maybe we need to modify for that individual coming into for a healthcare visit, so that from a sensory perspective, we're removing as many of those barriers as we can. Because I really see the environmental stuff as like the low-hanging fruit, right? It's as easy as potentially dimming a light or having a quieter environment, etc. this is a model that's based on an occupational therapy model, and the OT model is called the PEO, or Person, Environment, and Occupation model. And I had a student that worked with me that helped me to really make more clear all of these different pieces of my role that I'm doing, and so she created this modified person, environment, occupation model. So I'm just going to briefly share about it here. So over here on the left are what would be the people. So I'm thinking about the patient, I'm thinking about the caregiver, and I'm thinking about the providers and the staff. And what are the kind of specific things about each of those people that I need to understand to then try to make this what we call occupational performance, which this is like when we have success at a task, be optimized. On the other side of the, what does the patient need to do and accomplish during this setting? What are the tasks the caregiver is doing as far as being a support person? And what are the providers and staff need to get done so they can get the medical information that they need to move the care forward? And then finally, the environment. And so how do all these things come together? And the better I can help these to come together, that bigger that inside circle gets, the better the fit. So this is really, when I approach a situation, how I'm thinking about it. I found this quote and I love it, and when I do education at the hospital, I always include it because I think it's a great rationale for why we need to use an accommodations perspective. It's by Dr. Paul Collins, who's a writer, and he wrote, "Autistics are the ultimate square pegs, and the problem with pounding a square peg into a round hole is not that the hammering is hard work, it's that you're destroying the peg." So when people are coming in for a healthcare visit, if we are expected people on the spectrum to just adjust to what we need to accomplish as healthcare providers, we are not shifting their ability to participate with us, we are destroying the peg. So we need to do all the work that we can to think about how can we modify our approach, how can we modify our tasks that we need to do, the environment to try to help support their participation. So I think of myself like a detective, and this is what I call my proactive accommodations approach. So you can see again, it's this patient, provider, and systems level. So when I am consulted on a patient, one of the first things that I'm thinking about is, okay, who is this person? And I have a list of other things, how do they communicate? What are the sensory differences? How do they respond under distress? What are their previous healthcare experiences, thinking about that trauma perspective? What strategies have been successful before, or do we think we could use now? And who's going to be supporting this patient? I think about the provider and the staff. So what do these providers need to accomplish? What supports do they need in order to be successful? And what barriers might the environments that they're in create, and how can we mitigate these barriers? Because I will tell you, my experience by and large has been that providers and staff always want to do the right thing. They just don't always know what that right thing is. And it's not always easy to know what the right thing is, because the right things are often very highly specific. And then we're thinking about the systems level, okay, what are all the kind of components of this healthcare visit? Where is this person going to be going? But besides walking in the front door, now they're in the lobby, and then they're going to go to a waiting room, and then an exam room. Then afterwards, they're going to need to have blood work done, and then they're going to need to exit, and I forgot the parking garage too, because that's another big one. Go back out to the parking garage to their car. And what are all of the things that maybe we need to modify within that interaction that then can help that person be successful? And then also from a systems perspective, okay, in that example, this person's going to be on all these different locations with all these different providers and staff. How can I pull together communication so that we are all on the same communication? Everybody's getting all the same information. All the information is relevant and specific to what they need. And what gaps might be existing that maybe I need to think about? How can I fill this gap or figure out a way to? hands down, the most effective intervention that I've done is a care plan, which I know there's a lot of talk about care plans out there, and it seems, but it's as a communication tool, and I'm going to talk through these, why I think my care plan is effective. So one, it includes really specific, the highly specific information about a patient, but it also includes strategies that we may need to think about as really specific to medical tests and exams. So how can we support them best? For the provider, the information in my care plan also is really relevant to care interactions. So I'll show a little bit more about this, but one example is, under how someone expresses themselves, I have how does someone express yes, no? Because there's a huge variety of ways in which people either do or do not express yes, no accurately. And often when someone is maybe not able to understand information as well, as far as complex information, or be asked more complex questions, one of the first things that we're taught to do is to move to asking yes-no questions. So if that person's yes-no response isn't reliable, it's really important for our providers to know that. Or if there's really specific ways that person does it. It provides accommodations and strategies, and it's also highly visible. So I think this is really why this care plan is so effective, is that once it's completed, I put it in an electronic medical record in a couple of places that are very visible, but also cross healthcare encounters, so that anytime this patient comes back, or even goes to another hospital in our hospital system, it's there, like it's easy to see. It's not like it's buried in my note from 3 years ago, and so I really think that using the medical record to share this information, I've gotten a lot of feedback from staff on this too, is one of the key ways to promote learning and best care for our patients, and help our providers and staff feel more competent and confident as well. And so I am involved in some work, both in Mass General Brigham, but also in a smaller national group with disabilities, on thinking about how can we improve disability data collection and representation within medical records, because we have information like sexual orientation and gender identity, race and ethnicity, religion, language spoken, but we don't have a consistent way or place in which people are identifying as a person with a disability and the accommodations that they need in healthcare settings in a standardized way. Just going to share a few slides about, that have some examples of my care plan. So this is an example of communication. I'm sorry, this is a little small up here, but you can see, I'll just use this top one. So for example, how someone expresses a basic need, like if they're hungry or thirsty, that sort of thing, that's really key, right, for in a healthcare setting, especially when someone's inpatient. And so this is a patient who will say, I'm thirsty, I want coffee, drink, water, hot chocolate. But he may ask for medicine, but this is because he gets hot chocolate after he takes his medicine at home. So what he really wants is hot chocolate if he's asking for medicine. So it's just not really highly specific information that he said medicine to a nurse, and I wonder if he's in pain, let me go get some Tylenol or whatever, or something like that. But what he really wants is hot chocolate. So that's that key information about the patient, but then here's the information that's more directed for providers. So things like pause after giving directions, use only simple terms, use the words first and then finish to communicate the sequence of steps. But for this particular patient can perseverate on wanting coffee. So he'll say, I want coffee, I want coffee, I want coffee, and he won't stop. So if instead you respond with, when do you get coffee? He'll then say, after, and say, okay, after, or after appointment, and you can tell him, yep, you can have coffee after or later. And that this typically helps to redirect him from perseverating on asking for coffee. So again, it's just like highly directed and specific information in a situation where he could escalate if he keeps perseverating on the coffee. And this was a patient who was inpatient with us for several weeks last summer, but did great. I have a section also on pain, and because I know pain is really complicated, and I wanted to include kind of the whole list here, especially for people who are watching outside of our time today from home, just to have the opportunity to see, from my experience in working with patients and families, and I did have patients and families who helped me create this care plan too and gave feedback over time, that there are a variety of ways in which someone can communicate about pain. When someone doesn't communicate about pain in a typical way, these are all of the different kinds of behaviors that we could see that's a potential pain behavior, and then some strategies to determine their experience. So this is from a care plan that's more specific. So, it has some of the standardized options that are available, like reports pain that's unable or inconsistent with describing it, but then has some more, that the person has a high pain threshold, so it can be difficult to assess. And down here, another more directive strategy. You can ask, does this hurt while touching the body part you're assessing? However, the patient's not always consistent with their yes/no, even when in pain. So again, just taking that into consideration during evaluation. There's a section for safety, and so this includes, what are all of the ways that a person expresses pain, illness, or distress that could affect that person or staff safety. It includes things like aggressions, throwing objects, self-injurious behavior, bolting, wandering, pica, poor safety awareness in general. It includes the warning signs that someone may be starting to escalate, and some accommodations to help with how can we help them to stay as calm or safe as possible. It includes stressors, so the ones that are on this care plan are like discomfort not being addressed, but again, I have a long list in the general care plan that are typical ones that we've found over time, and then also sensory stressors. So for this person, it's really that sticky or scratchy textures. And then as far as more specific accommodations that are directed, which is helpful for people to be aware of, for example here, again, it's like standardized things like reduce noise, allow the patient to walk or pace, but then I like a comment that provides more specific at baseline, the patient's constantly moving or walking. Sometimes in the hospital setting, when it's very busy and there's a lot going on, for example, in the emergency department, if someone's up and pacing and moving a lot versus like laying in their bed or sitting in a chair, that can be interpreted as, ooh, okay, this person's starting to like escalate, and it could heighten concern about someone. But for someone who needs to move constantly at baseline, when we have that information, we can do a lot with it. We can get them in their own bay with the door. We can get the stretcher out of there so that person can move in their room. We can get a rocking chair from like the maternity wards down in that room so they can rock. In the past, the occupational therapy department has therapy balls that people could sit on and bounce. These are all ways to make sure that we're providing the person with the movement that they need to self-regulate in the environment, while also thinking about how do we also make this a manageable situation for staff. Then I have a whole slew of accommodations. There's some here like crowded areas, the hospital room, transport, being on the stretcher, hospital clothing, the ID band on the wrist, and it's divided into, does this person not need any accommodations? Because that's really important for our staff to know too. So if this person does great with vital signs, they don't need to be necessarily as concerned or cautious or that sort of thing. If they do a great job of that, or if they can tolerate wearing the ID band. But this will then describe, really specific tasks that we do all the time, and for when there does need to be a difference, what we can do and offer. And the accommodations were all created in collaboration with my champions in different departments as far as figuring out, okay, well, here in endoscopy, what can we do, as far as an accommodation or on an inpatient unit or in the OR areas, what can we do so that the accommodations that are here are really relevant and specific to the people, the staff and the providers, and then you can be like, oh yeah, okay, no problem. We can put them in this particular bay with this door, it'll be okay. Or we can transport them in a wheelchair instead of on a stretcher because they're afraid of stretchers because of the previous traumatic experience. Here's my process. So this is for outpatient, but it's a little bit, it's basically the same for inpatient too. I get a referral, then I do outreach to the patient and family. I do a lot of preparation, when people are coming in as far as creating a care plan, learning about from the team and the patient and the family, what their concerns are, communicating that care plan, creating tools, that I'll give you an example of in just a second, and providing some day of support. And then finally, future support. So one of my favorite things about this role is that I get to continue to help. So about 45% of people of consults, I should say, that I get every month. I get about 27 consults a month. That's my average. About 45% of those are people that I've worked with before. So I really get to know patients and families over time, especially ones that need to come back again and again and again. Or during times of illness for someone where we're trying to figure out what's wrong with this person. So I can be that person that's that consistent person for, okay, they came to the ED, now they're on an inpatient, now they discharged home, now they're having a specialist visit, now they're coming back for imaging, now they need to go to phlebotomy. I can help with making sure that the people are aware of the person. And if the care plan's in the record, it makes my job super easy because I can just bring their attention to it, and get everybody on the same page. So here's an example of a patient that was last fall. So this is a 35-year-old adult on the autism spectrum who had a skin abscess that was not responding to antibiotics. He needed an evaluation of the abscess and possible debridement and drainage of that abscess. He had an MGH PCP who was really concerned that an ED visit may be needed soon if he started to develop a fever. This is an MGH PCP. So he reached out to me to see how could I help this person. So this individual was fearful of medical settings due to history of trauma in part. So he, for example, required physical assist from 5 officers plus 2 phlebotomists to get a blood draw done before. And he's terrified of needles. His wait time, his ability to wait is only 2 to 3 minutes. He's unable to wear a mask, becomes assaultive or bolts when frightened. And over here, I won't go through this, but this was my process. Outreach I did, outreach to champions, outreach to a surgeon, got into the surgical clinic, collaborated with planning, communicated on the plan, and then reviewed post-plan. These are the accommodations and care strategies that we did. So we made accommodations for arrival, specific information for the exam, communication tips, and information about support persons. We were able to get this patient in through a side door directly to an exam room where then the provider was already waiting. Because this patient's tolerance of only being able to do 2 to 3 minutes was clearly going to be a barrier before he was attempting to elope. One of the challenges was around, how are we going to get this patient that the provider needs to be able to visualize and palpate the back. So one of the things that the group home staff and that mom helped me understand was what the provider needed to be able to say to accomplish that. So the example was, okay, if you say we're going to touch your back, or I just need to take a look, he interprets that very literally. A touch is just a touch, a look is just a look. But his group home staff he had been letting them clean it for a longer period of time. So we said, okay, if you can say, I'm going to clean your back, he'll likely allow you to touch it for a longer period of time to be able to, feel what's going on in there. So I provided all that information to like our team. I also created a visual support. I went over to the clinic, I took pictures, stepping in, kind of going in and coming back out because mom shared this is something that would be effective for this patient. And then this was, I love my officers that are my champions. They wrote with feedback saying, in fact, he paid little attention to us. He seemed to know where he was going and determined to get there. I'd also like to note it was extremely helpful that the staff was very well prepared for our arrival. Provider was waiting for us, got the patient in the exam room. Once we arrived on the floor, the entire process took approximately 3 minutes. So it was like really exciting that this individual who's really complex, we were able to get him in and get him back out. And because he had the visual support, I believe he also knew where he was going and determined to get there. And it was efficient and done, and the provider was able to get done what he needed to. I think I'm about out of time, so I'm just going to jump ahead. I had a student that did a qualitative analysis and interviews with three individuals, 2 parents and a patient. And so this was some of the feedback that were, these were some of the interventions. Here's some of the quotes. This was a patient, they bring me to a separate waiting area so I don't have to wait in a really crowded waiting room. The OTPN, like OT Patient Navigator, helped him to develop this care plan that has changed our lives. It literally changed our lives. She paves the way, she talks to the doctors and people that are involved so things can go smoothly. I also did a staff survey on effectiveness, which this was after I had been working with a couple of units. So it's a really small N of 32, so it's nursing. And so, they reported that caring for individuals with a developmental disorder compared to typical population was overall either moderately difficult or neither easy nor difficult. However, with interacting either with me or with using my care plan, about 75% felt more comfortable, about 80% felt more competent and efficient. And they also felt, the same amount of 75% felt they had more control or autonomy with their practice. This is kind of feedback from colleagues and champions. This top left one, the key piece in here is, we cannot just learn concepts about caring for autistic patients. The individual care plans and coordination are necessary. I'm sure the patients are receiving the care they need because of this. Our department would not be able to give the same level of detailed preparation to patients and their families coming in. Without parents troubleshooting in advance, some families would never even try to bring their child into the hospital for necessary care. So what if you don't have a patient navigator? What do you do? So I've had this come up a number of times, but recently I had a wife and husband in Florida. Husband is on the spectrum, and he's a scientist at baseline, but he had a medical issue that came up that then he had a really difficult time in the hospital. And then his wife actually found the Asperger Autism Network that's out of Massachusetts, and then they referred it to me. So I sent my care plan to them. They filled it out. I went on to the hospital system's website where they were down in Florida, and I figured out, okay, this is the department you should take the care plan to. So it was like the Patient and Family Relations Department. So I think if you create a care plan that has some key information, but that's also really specific to the medical setting, more directive to providers, versus I know some families that will write a couple of pages, and then you think about, okay, who handles complaints, So this is often from a disability perspective or ADA accommodation perspective, and or if the visit is very straightforward, then you can reach out to that specific department. So in closing, I just want to share how individuals on the autism spectrum and the IBD experience unique barriers to healthcare. However, interventions that are focused on proactive planning, modification, can help promote their access and participation. And care plans that are highly specific to the patient, relevant to patient, to staff and healthcare visits, and in a highly viewable location can be a invaluable teaching tool because it allows that kind of in vivo and bedside, as well as successful experiences for patients and staff. So my acknowledgements. I just want to say happy Autism Awareness Month, and it's also OT Month, so happy OT Month as well. Thanks so much.